Hello everyone, my name is Dr. Victor Baldea, and today I will be presenting you transient elastography. As many of you probably know, transient elastography was the first elastographic technique released on the market over 10 years ago, and since then many published papers have proven its value in the field. It was introduced as an alternative to liver biopsy with very good accuracy for ruling in and ruling out advanced fibrosis and liver cirrhosis. Today, I will be examining a patient without known chronic liver diseases. Firstly, we start the examination with the patient positioned in decubitus on the bed with normal breathing in a relaxed state. We have firstly, as a note, the FibroScan was released with the M probe, which had this is the M probe, which had a lower reliability and technical success in patients with obesity, with around 75% success rate. Afterwards, the Excel probe was released to overcome these limitations of the M probe, which led to an increase in the technical success rate above 90%. I usually calculate the BMI of the patient. With this system, we also have an automatic probe selection tool which enables us, which guides us in choosing the correct probe based on the patient. I usually start in patients with BMI below 30% the examination using the M probe. If, for example, I don't obtain 5 consecutive valid measurements, then I switch to the Excel probe. So, with the patient positioned in decubitus, we perform the examination using as a guide the mid-axillary line of the patient. So, in an intercostal space along this line, above 1-2 centimeters, usually maybe 3 centimeters above the rib cage. So we position the probe. As you can see in the image, we have several guiding lines. One guiding line is a bidimensional representation of the liver parenchyma. So when we have homogeneity here and a continuous green line, then we are able to perform the measurements. Another guiding line is this segment in the where I'm pointing now. We have to have a linear diagonal line from the right side to the left side. This is the pressure of the probe, a guideline for the probe pressure. You see, when it's one line, we need to push more. When we push too much, we have a warning sign that tells us to release a bit the pressure. So when we are ready to perform the measurements, we need to have a continuous green line in both images, and we press the button located above the M sign on the probe. Okay, now we have an invalid measurement. We switch a bit the position. Another invalid measurement. Okay, now we have a good measurement. We wait a bit for an homogeneous line. We perform 10 measurements. After performing 10 measurements, we have the values reported. With this system, we also have liver steatosis quantification using the controlled attenuation parameter, which is displayed on the left side of the image. Okay, now I will perform 10 measurements and we will discuss about the results. I don't know if you can see, there are sometimes like white lines along the image. Those are rib shadows. Okay, now we have 10 measurements. The values we obtained are displayed on the right side. We also have a graphic with the values, the dispersion of the values on the bottom part of the image. So the values obtained are 3.5 kilopascals with an IQR per median of 21%, which is a reliable measurement because most elastographic techniques use as a reliability criteria the IQR per median value below 30%. In terms of liver fibrosis estimation, this value of 3.5 is corresponding to no fibrosis. The cap values which we have obtained here is 257 with an IQR of 52. Okay. The IQR value, ideally, we considered a highly reliable measurement value below 40. So this is the presentation of a patient without known chronic liver diseases, where we performed the transient elastography. Thank you. I will be presenting you the evaluation using transient elastography of a patient with chronic liver disease secondary to alcohol consumption. First, we start by positioning our patient in decubitus. As many of you know, transient elastography was the first non-invasive elastographic technique developed in using the FibroScan system. First, it was introduced with the M probe, followed shortly after by the introduction of the XL probe for obese patients. In this case, in this particular case, we will perform the examination using the XL probe because our patient has a BMI over 30. First, we perform the examination by using as a guiding location an intercostal space in the mid-axillary line. We draw an imaginative line in the mid-axillary line and in an oblique line by the sternum. We position the probe in an optimal location for us. You can see in the image that we have several guidelines. This is the image of the representation of the liver parenchyma, and this is the wave which we will be generating. Ideally, we have to have a diagonal line from the right side to the left side. When we are ready, we perform the measurement by clicking the button in the XL location. Okay, we have our first measurement, which is 36.3. Then we perform 9 additional measurements until we have 10 valid measurements. We always take a brief moment between measurements. We don't it is not recommended to perform the measurements rapidly. We can wait a few seconds between measurements until we have like a green homogeneous line in the upper part of the image. In this system, we also have the CAP module implemented, which is the controlled attenuation parameter, which evaluates liver steatosis. The CAP values are shown on the left side of the image. We also have a numeric scale on the lower part of the image where we can see our recorded values and their distribution. Okay, now we have 10 measurements. The value obtained using transient elastography is 34.8 kilopascals with an IQR per median ratio of 7%, which is a reliable measurement. We have to, the IQR per median value has to be below 30% for an accurate assessment. The CAP value which we obtained is 251 decibels per meter, which is with an IQR value of 29. We considered reliable CAP estimate measurements with an IQR value below 40%, below 40. This value is a value which corresponds to liver cirrhosis. There are many meta-analyses which appeared, and a value of above 12 kilopascals is a value which is a high probability that the patient has liver cirrhosis. Also, you can see this is another guiding system for performing fibroscan. We have to have a narrow line which traverses the liver parenchyma, and it can be used as guiding as well. So without further ado, the most important thing is that we obtain 10 measurements that are reliable. The IQR per median value has to be below 30%. When we refer to CAP, we have to have also 10 measurements. Ideally, the IQR value has to be below 40%. The value which we obtain here is 251 decibels per meter. Judging by the most recent meta-analysis that appeared in the literature, this value is indicative of maybe mild steatosis or no steatosis. Unfortunately, we do not have an ultrasound machine here, so we cannot perform an visual objective assessment of the steatosis in this case.